Hi everyone, I'm Dr. Niharika Jain Gupta and I'm an endodontist. Besides, I'm also Executive Director of Epistate Health Singapore. I take immense pride in hosting this innovative program, an initiative by Epistate Health Singapore, which is known as One Among You. So the basic idea of uh, coming up with this One Among You program is to invite all the passionate dentists. Just a minute, please. All the passionate dentists. Yeah. The basic idea of this program is to invite all the passionate dentists who are working so hard and with a lot of dedication and zeal in the field of endodontics. And now we are hosting our session with the prize winners of recently organized case contest by Epistate Health Singapore. So we are going to invite the prize winners to share their outstanding cases with us in each episode, where they're going to discuss about their expertise and the real time, real challenge which they face during the cases. So first in line is a beautiful speaker, Dr. Manasi. So Dr. Manasi Surwade won second prize in beginner category of the case contest, which was organized by Epistate Health Singapore. So Dr. Mansi is a skilled, beautiful dental professional who is specialized in conservative dentistry and endodontics. She holds her MD's degree in conservative dentistry and endodontics. She completed her post-graduation from Mahatma Gandhi Mission Dental College, Kamote, Mumbai, and also she post-graduated as a topper in her field. She is the owner of Dr. Mansi's Manifest Dental Studio, which is in Kharghar, and serves as a faculty member at MGM Dental College, Kamote, in Mumbai, India. Her expertise spans cosmetic dentistry, root canal treatment, innovative dental research, with multiple publications in esteemed journal and also a copyright for an LED mouth mirror. Congratulations, Dr. Mansi, for this.
Thank you.
Dr. Surwade has received prestigious awards for her research presentations, and also she is an active member of professional societies like Indian Endodontic Society, Indian Association of Conservative Dentistry and Endodontics, and Academy of Cosmetic Dentistry of India. She is committed to social service, providing free dental care to underserved communities. So yes, may I now welcome Dr. Mansi to please come and share her clinical prize-winning case with us all. Also, Dr. Mansi, the recording of this program will be available on social media. Besides, if anybody has any doubts, they can post their questions on social media. So, over to you, Dr. Mansi. Please go ahead.
Hello, Dr. Niharika. Thank you for such a good introduction for me. Okay, so I would like to continue saying that hello everyone, I'm Dr. Manasi Surwade and I am a faculty member in MGM Dental College, Kamote, which is in Mumbai, India. So I won a second prize in the advanced category actually for the Epistate Endodontic.
I'm so sorry. Yeah.
Oh, it's okay. No worries. So I'll be sharing this very rare and exceptional case of a mandibular molar, which was having 7 canals, and I completed that using the Epident rotary file systems, which are very good actually. So let's get into how I was able to tackle this very rare anomaly.
Yeah.
Okay, I'll just share my screen. Let me know if it's visible.
Yeah, sure, please.
Okay. Dr. Niharika, is my screen visible?
No, Dr. Mansi, can you please share it again?
Okay.
Yes, now it's visible.
Now it's visible.
Yes. Yeah,
Okay.
perfect.
Shall we start?
Yeah, please go ahead. I'm
Okay.
sorry for this, Dr. Mansi,
Uh, for what?
for introducing you as second prize winner in beginner category. I'm so sorry. That's
No,
advanced category.
it's okay. It's okay. It's fine.
Yeah, please, let's go ahead.
Okay. So the title of my presentation is Enhanced Diagnostic Precision using the CBCT in Endodontic Management of Mandibular Molar with 7 canals. This is my case presentation. So the contents of my presentation are introduction, case presentation, discussion, conclusion, and the references. So coming to the introduction part, any mandibular first molars or second molars, they typically exhibit a complex root canal system, often presenting with 2 or 3 roots and a variable number of canals. However, the presence of a mandibular molar with 7 canals is rare and exceptional anatomical variation. As we can see in the first picture, that is the first and second picture, it is a micro CT image involving the the representation of mid-mesial canal, which is confluent merging with the mesolingual canal. Similarly, in the second image, we can see the same scenario. Coming to the second image, which is of CBCT analysis, this section, as we can see here, it is the axial section of CBCT analysis, and this is the coronal section of CBCT analysis. In this, we can see this faint dot. This is how we identify any multiple canal that is present with the help of such diagnostic aids like CBCT. Again, in the coronal section, we can see there's this radiolucency, which can be seen from the pulpal orifice till the radiographic apex here in the second picture. Similarly, we have an animated version of it, wherein the purple color shows a mid-mesial canal ranging from the pulpal orifice to the middle to apical third of the root. So this case that I'll be sharing, it highlights the importance of such detailed diagnostic tools such as the CBCT, that is the cone beam computed tomography, and the meticulous exploration during the root canal therapy. So the recognition and the management of such additional canals ensures the thorough cleaning and shaping of root canal, and the proper prognosis of it depends on that. So coming to the historical prevalence of such cases, in 1981, Pomeranz et al. He reported the anatomical variation of mid-mesial canal, which ranges from 0.2 to 46.15. In the recent studies that have come up, the percentage has increased more due to such diagnostic aids that are available with us, like micro CT imaging or the CBCT imaging, etc. Coming to the Indian population, overall, according to Bharatia et al. In 2024, the prevalence of mid-mesial canals in the Indian subpopulation was seen as for 8.6%. It has been correlated with the age as well. Nusrat et al. She reported the incidence of mid-mesial canals. Mid-mesial canals were higher in younger patients. That is, the patient who are younger are having more number of mid-nasal canal, all the mid-distal canal.
I'm sorry to interrupt. Your screen is not visible, doctor.
Not visible?
Can you please reshare that? Yes, can you please reshare that?
Okay, I'll just... is it visible now?
Yes.
Okay. I'm so sorry from my end.
No, that's okay, please. Totally understand.
Okay. So coming to the correlation factor of mid-nasal canals or mid-distal canals, it is seen by Nusrat et al. That the incidence of mid-nasal canals or mid-distal canals was more in younger population. As we can see on the screen, it is around 32.1%. But the patient who are older than 30 years, that is from the age range of 31 to 40, they have a lesser number of mid-nasal canals or mid-distal canals, as well as it is seen even lesser amount when the patient's age increases. So this is how we can correlate it clinically. If a younger patient is coming to you, you know that there is a high chance or high prevalence of finding the extra canals in such patients. So coming to my case presentation, a 27-year-old female patient reported with a chief complaint of pain in her previously initiated treatment, as she said, in her lower left posterior region of jaw in the past 3 to 4 months. She said that the pain aggravates at night. Upon examination, the cold test, it gave a delayed response, and on the electric pulp testing, the response was 29, which corresponds to the delayed response. So this gave to a conclusion that it is irreversible pulpitis, symptomatic irreversible pulpitis. Next, coming to the tooth, it tested positive for percussion. This came to a conclusion that, okay, she is having a symptomatic apical periodontitis. So this was how we concluded what would be the treatment plan for such patient. So upon the radiographic examination for the tooth number 36, the radiographic examination showed that there was radiopacity involving the enamel as well as dentine. Slightly, there was radiolucency below the radio-opaque material, which suggested that there might have been a microleakage, which resulted in causing pain in such patient. In this two-dimensional image, when I observed this image, one of the mistake I did was I did not take multiple angulations of it. So here I have a tip that please do take multiple angulations. That is, either it should be straight, mesial and distal. All three angulations are important if we want to see if there is any chance of multiple canals. Okay, so in this image, which is a straight view, we can see there is radiolucency, but which is faint. We can see this 1 and this is 2. And they are merging together with a higher radiolucency here, which is suggesting that there might be a merging of both the canals. Again, here in the apical end, it is splitting again. So here we can observe and think that, okay, there might be 2 portals of exit, not 1. Coming to the distal root, we can see there is radiolucency here and there is a fast break here, which is suggestive of either there can be 2 or 3 canals. Coming to the middle third to the apical portion, we can see that the radiolucency has maintained itself, which is suggestive that there might be a merging of 2 to 3 canals here. So this is how we can depict how even a two-dimensional image, if we have to go in for any CBCT or any other diagnostic aid, if in two-dimensional image we are able to visualize this and understand that, okay, this case might go for a CBCT, might need CBCT. So coming to the next part, that is the root canal treatment procedure. So any procedure that we do for root canal, we have to take the patient's consent before administering anesthesia. So we gave an inferior alveolar nerve block after she consented for the same. So next part was the orifice enlargement and pulp tissue extirpation. This was done after the removal of the previous restoration was done and the orifices were located. So for this case, I had used engine-driven Epident ultra flexibility NITA rotary files, which were used for the treatment. So initially, only main canals were located. That is the mesiobuccal canal. There was a very large oval mesiolingual canal, and there were 3 distal canal openings which were located after access opening. So I was able to visualize 3 bleeding points in the distal root and 1 mesiobuccal and 1 very large mesiolingual. So the additional canals were identified later on using CBCT scan images. So this made me go to the next diagnostic aid, that was the CBCT analysis. That is after seeing 3 distal canal openings. The orifice enlargement was carried out with the first file that we can see here in the picture that I've added. The orifice enlargement, it was carried out with the Epident NITA file orifice shaper, that is FX, and which was followed by canal negotiation and apical patency, which was achieved with 10 number K file and 15 number K file. So after that, I did a CBCT analysis, that is after just extirpation of pulp, because I was sure that, okay, there are 3 bleeding points that I'm observing in the distal root. This made me think. Next, one of the major factor why I did was there was a very large mesiolingual canal. So any canal which is very large compared to the other canal, there might be a thing that we might feel that, okay, I might have not perforated it or something. But do not be scared of such things because sometimes there might be a split. So this made me rethink of doing this. So when the cone beam computer tomography came in for this patient, as we can see, there are slices. So each slice, as we go from number 13, 14, 15, 16, 17, 18, as we can see in this photo, there is a distance of 1 mm. So when we go from the apical end here, from the 13 number, we can see there is radiolucency in the mesial aspect and there is radiolucency in the distal aspect. Okay, so there is one huge radiolucency. This was the picture of 13 image that we have taken as soon as we did the access opening. So this was the access opening thing. Then on the 14 image, we can see that there is a radiolucency in the middle of both the canals. So this marked the mid-mesial canal. Also, while doing access opening, there was mesiobuccal canal which was exactly below the mesiobuccal cusp, and there was the mesiolingual canal which was at a very huge distance from mesiobuccal canal. So this made me question that, okay, there might be a multiple canal here. There might be a mid-mesial. That is how I thought of doing this. Then in the next image of 15, we can see there is this radiolucency, which is still again very much oval, as we have seen in 13, 14 and 15. There is a mid-mesial canal here again, we can see, but the radiolucency has decreased a little. So this makes us think that, okay, it might end in the middle or the middle third, around middle third area, because as the radiolucency is decreasing, the canal is ending there. This is how we can make out. Then the mesiobuccal canal is fine here. So in the slice number 16, as we move from 1 to 3 mm below the pulpal orifice, we can see there is mesiobuccal canal, which is almost at the one end. There is this mesiolingual canal. Now the ovalness of this radiolucency has decreased. That is in the mesiolingual canal. So again, we can still think that, okay, this oval canal, it might have a split, which is again ending in the apical third, because the radiolucency is decreasing. Okay, in similar manner, we can see all the radiolucencies for 3 distinct dots here. That is 3 canals we can see for the distal root, which are continuing, and it is painting again in the slice number 17 and 18, which we can see and understand that, okay, they are merging together. So they will have one portal of exit. Whereas for the mesial root, we can see that 1, 2, 3. At least we are having 3 portals of exit here. Mesiobuccal having a very separate portal of exit. Mesiolingual and midmesial might be merging together in the apex. So this is how we have to read a CBCT when it comes to us. This is the axial view. In axial view, we can correlate it better, because when we observe it clinically, it's from the occlusal end. Okay, so the next step for doing this was troughing, which was done under rubber dam isolation, and it was done under illumination. So I have used a dental operating microscope, and all these pictures I've clicked under 1x magnification, and all the procedures were carried out using rubber dam isolation. That is an unsaid rule that we have to follow. Okay, so one of the things that I wanted to point out here is the blue marking that is seen here. So this blue marking corresponds to the mesiobuccal cusp. So whenever we are doing any procedure under dental operating microscope, we tend to forget, or we tend to not understand when we look back, that was it really mesiobuccal or was it really mesiolingual? We are not unable to understand it because we do it under indirect vision. So this is one of the things that has been thought by our head of the department, ma'am, Dr. Sumanthini ma'am, to me, and this is the system that we follow in our college. Okay, so after troughing, so the basic troughing that we do, it is done with ET18D. So the D stands for diamond coated tip. That is, the diamond will erode the surface. That is actually used for troughing. Then I used ET20. ET20 is only ET20. So it does not have any diamond coating. So it is just used for the refinement of it. So this troughing is done about almost 2 mm below the pulpal floor. Okay, so as we can see in this photo, we can distinctly see that there has been troughing done. So another surprise that I got was in the CBCT analysis, we were not still able to distinguish what would be the mesiolingual canal. Why is it so wide? But after doing troughing, for even 1 more mm, I could visualize that there was a split in almost the end of the coronal third to the start of the middle third. So this is how I got 4 canals in the mesial root and 3 canals in the distal. So this is distinct mesiobuccal, mid-mesial, mesiolingual 1, mesiolingual 2. Here it is distobuccal, mid-distal and distolingual. So this blue dot, it makes the identification and the statement of which exactly is the canal very simpler. So this is one of the things that I think everyone should follow. So okay, this is how I got all the canals here, and this I have attached a little picture of this ET18D. So this we can use for troughing. Okay, so coming to the next part, that is the working length determination. So electronics apex locator was used to confirm the working length. So in the mesial root after the orifice enlargement, mesiolingual 1 and mesiolingual 2 almost merged together. This even we were able to understand because there was this very wide mesiolingual. So we knew that, okay, it might just merge together. In the distal root, the mid-distal canal was seen to merge with the distolingual canal. Here we can see in this, so we can see this merging of mid-distal canal. In the mesial root, the mid-mesial canal was seen as a short independent one. Here in this photo, it is not very clearly seen, but we can see the end here, mid-mesial in this picture. So in both the roots, for the mid-distals and mid-mesial, we can state that the canal system was categorized as the confluent type. So I have made a very small box here stating what is the how many canals are there, what was the working length of them, what is the initial binding file of each canal, and what is the master apical file. That is the master apical file, that is the preparation I did for the biomechanical preparation. So coming to the initial binding file, I was having a binding of mid-mesial with 10K number file, again with mesiolingual one 10K, and the mid distal one again I found it with 10K. But still I prepared all of them till 25. I mean 3 sizes larger. That is the unsaid rule that we do. So this was my final preparation. So the canal preparation procedure, as I explained earlier, the file system that I had used was the Epident Ultra Flexibility NITI files. The apical third I had enlarged up to 25K. So the file systems come in with a 6% taper. So the preparation was 6%. And one thing we have to do in such complex anatomy, we have to make sure that we recapitulate it every time after changing the instrument. That is with 10 number K file. We do it after each instrument change. Then the passive ultrasonic irrigation was used. I will state that the importance of irrigation activation is must, because there are isthmi, there are apical deltas, there are fins, there are a lot of complex things happening. A canal is never a straight line. It is never a straight line. So there are lateral canals, there are fins, isthmi, and every. So all these things cannot be cleaned only with biomechanical preparation and your traditional rotary system. We need irrigant activation for this. And as stated by Vandus Lewis in 2007, in one of his article, which is a very famous article in the International Endodontic Journal, he stated that how passive ultrasonic irrigation is of utmost importance and how it is better and very efficient than all the other irrigant systems that are available. So I personally prefer passive ultrasonic irrigation, and for that I used a 15K U file. Now, next let us go into the irrigation protocol that I followed. So I use 3% sodium hypochlorite solution for 3 cycles each. That is 3 times I reuse that for 20 seconds, each utilizing a total volume of around 6 ml each for 1 canal. Similarly, the final irrigation protocol is also different. Here we use EDTA, that is the chelator, to just remove the smear layer. Again, it is used in a similar manner, that is the similar concentration and the similar time, that is 20 seconds and 6 ml. Now next, coming to the master cone selection. So in master cone selection, one of the things that I practice is whenever we are selecting a master cone and before taking radiograph, we have to make sure that we take the master apical file. That is the 25K number file in my case, because I've prepared it till 25.6%. So I will take the file, and again I'll use the electronic apex locator to see if there is any if I'm reaching up to the apex. That is mostly we try to keep it 0.5 short of the radiographic apex. So in this view, we can see there are 3 gutta-pacha points in the distal canal. Similarly, in this view, it is not that clearly seen. Here in mesial view, you can see 1, 2, 3, and 4. So 4 gutta-pacha points were fitting perfectly. Here, as we can see, 1 mesiobuccal canal, it is independent, as we have seen in the CBCT. Similarly, we can observe it here. For the mid-mesial, we can see that it is ending here. For mesiolingual 1 and 2, we can see it is almost merging together and it is having 1 portal of exit. For the distal canals, we can see there are 3 different gutta-percha points, all of them merging together and having one portal of exit. Sorry. So I completed the obturation of this tooth number 36 with a single cone technique, but using a warm vertical compaction after using the single cone. This is something I do because I find that it will just end up giving me a 3-dimensional obturation, which I always strive to achieve. This is one of the things that I do. And here in the distal canal, again, we can see this is 1, 2, and 3. And in the mesial, it is 1, 2, 3, and 4. So this is how we can observe it. Then I use the sealer AH plus and the post obturation restoration for that. It is double seal technique. That means after searing of the gutta-percha, I use the GIC here. As we can see, it is almost dentine like. Then after that, we use a flowable. I use a flowable composite, and then after that, I use restorative one. So this is how we can avoid micro leakage chances in near future. So even the post obturation restoration, we should always strive to do a double seal technique. So what were the challenges that that I encountered during this endodontic treatment, and how, if I had done it traditionally, and how the modern techniques that have come up, even the diagnostic tools, helped me achieve this. So if it was a traditional technique that I followed, we were using a IOPA. So in IOPA, we just get a 2-dimensional view. 3-dimensional view, we will not be able to get. And the modern thing that we do now is the CBCT analysis. Here again, I would like to highlight, not every case will go to a CBCT analysis. So the first and foremost technique is, in the IOPA, if we can see any fast break, or if we can see that, okay, there might be some sort of complex anatomy of this tooth, only then such cases we will refer to the CBCT. For access opening, traditionally endo-access burr and indirect or indirect vision was used. In modern techniques, we use the burrs as well as we use troughing, and we do troughing with the ultrasonic burr that I had shown of that is ET18D, and we use the troughing with the help of microscope under magnification. This is must, because blind troughing can lead to perforation. So we should just never blindly do troughing. So for that, we need DOM, and we need illumination, and we need the ultrasonics with us. For the precise thing, see, because if we had done this in just traditional manner, we would have never been able to achieve the split that we saw for the mesolingual, the large oval mesolingual canal. We would have never been able to do it if we had used our traditional techniques for root canal. Also, I would like to highlight that the access opening, whenever we do, okay, so if we are using a DOM, we should just never try to do a ninja axis or I'm not against this, but we will not be able to clearly see this. You know, this split was only visible because we had done a conventional access cavity preparation. We have to modify the access cavity preparation if there is a thing like complex anatomy. Like this case demanded a conventional access opening. Then next, coming to the cleaning and shaping. Rotary file systems was used traditionally along with the root canal irrigants, but in the modern techniques we use them, but we have to add on with the irrigant activation that we have done. That is the ultrasonic irrigation system that I've done. For obturation, only lateral compaction technique was used, but we have to add in the modern technique that lateral compaction we have to add on with a vertical warm compaction with using our just hand pluggers. The GDC ones will also do. The post-obturation restoration, only permanent restoration was done, either it was amalgam or either it was composite. In the modern techniques, we do follow this rule of double seal, that is GIC on the pulpal floor, followed by composite restoration, just to avoid the chance of micro leakage. So now coming to discussion. What were the just giveaway points denoting any missed or multiple canals? So first is the unusual root anatomy, which we got to know after the CBCT analysis. But prior to that, for this patient, when I was just taking up this patient, before even access opening, I found that her tooth was bulbous. So next is the pulp chamber anatomy, the floor and the asymmetry in the canal openings. In this case, as we saw that the mesiobuccal canal and the mesiolingual canal both were very apart from each other. So this made us think that, okay, it might be multiple canals were there in this case. Any excessive bleeding or pulp tissue in any unexpected areas, which we can come to know by doing the champagne bubble test, that is the sodium hypochlorite, concentrated sodium hypochlorite, putting it in the canal, and the bubbling effervescence we can see from one of the spaces. It just makes it sure that, okay, it might be a missed canal here. Then resistance to deviations during instrumentation and champagne bubble test, which I've already mentioned here. So one of the thing that I do is to know if it is a independent canal or is it a isthmi or is it a fin. First, what we do is to place the 8 number K file or 10 number K file in the main canal. Then if we want to make sure if the it is a fin attachment or something, just consider if it is a mesobuccal canal. Then what we'll do, from the mesobuccal canal, we will move towards the lingual side. If the file is moving towards the lingual slide without any resistance or anything, then we can understand that, okay, it might be a isthmi or fin. But if we are getting a proper resistance there, or the file is just getting stuck, it is not moving lingually, then it is a independent canal. So this is how we come to know the confluent configuration. So this is a basic summary of how we can understand that there are multiple canals and what are the diagnostic aids, or what are the things that we can do for exploration of this. So first is the preoperative radiograph. How I've already said that even a two-dimensional radiograph will give us some idea if this case is a complex case, or is there any split or any apical deltas, just if we read the two-dimensional X-ray properly. Then going to the CBCT analysis, in such cases CBCT analysis must, if we understand that this is a complex anatomy. Even for mandibular molars, first molars, even second molars, because they have a C-shaped anatomy, this is something we have to keep in mind, that this tooth, there is a chance of having a C-shaped anatomy. So such cases we have to, from start only we have to make sure that we do the troughing and we take a CBCT scan for this. Then next, coming for the magnification and illumination. Dental operating microscopes and illumination along with your ultrasonics are must in cases of such complex anatomy. Even the careful access cavity design, we have to modify the access cavity to expose all the pulp chamber, to expose the pulp chamber flow, so that it will help us fully uncover all the hidden canals, particularly in the mesial and the distal roots. Coming to the tactile exploration, using the small files, how I said, moving it along lingually or buccally to know, to understand. This we can do with 8 number K files or 10 number K files. And even the DG16 endodontic probe is enough for any independent canal that we see. We get a catch here. Along with this, there are stains available, there are dyes available, methylene blue dyes. This will give a telltale sign that, okay, it is a canal opening might be present here. Then coming to the champagne bubble test that has already discussed, it is the sodium hypochlorite bubbling test that is expected at any unexpected site, which indicates the presence of any additional canal. Then coming to the ultrasonic troughing, as we have mentioned earlier, the ultrasonic tips are useful to remove and uncover the hidden canal entries. Even the split in the middle third can be uncovered with the use of ultrasonic tips. Not the ET18B, but ET20 can be useful in such cases. So this is how the two-dimensional image is not able to still completely give a fair idea that how the case would end up being like. So in such cases, three-dimensional view is required, which is the CBCT here. So I have mentioned hardly few two case reports, but there are many more which are done under using the CBCT analysis to confirm the root canal morphology, and it just enhances the clinician's ability to explore and understand the anatomy thoroughly and facilitate more effective root canal treatment. Also, this use of magnification, it enhances the endodontic procedure by reducing any risk of damage to the canal dentine. So in such cases, if there is a risk of perforation or something, we can still visualize it. Even in cases of open apex, we can clearly see the apex which is open and the granulation tissue which is formed below the open apex. This can be visualized under 2.5x magnification. So even the apical end, even the apical split, any bifurcation can be visible with the use of dental operating microscope. So this is must in complex cases. Next, coming to the ultrasonic stimulation that is helpful, that is the ultrasonic irrigant activation. So it works basically on two principles. One is the cavitation and one is the acoustic streaming. So the streaming, it generates the shear forces that helps us dislodging the debris. And the cavitation, basically it forms the bubbles here. So it is the mechanical energy which is used here. So this mechanism is working in two phases. One is the mechanical energy, that is the formation of bubbles and the bubbling and the cavitation that takes place. Then it is the warming effect of the irrigant, that is basically it warms the irrigant and thus it helps in complete disinfection. So this I would like to highlight. The use of CBCT is helpful in the access cavity preparation, locating multiple canals and thorough cleaning and shaping of such complex systems. So I would like to briefly summarize and conclude that identification is a crucial thing here. If we are unable to identify, we will not be able to treat. So identification of complex anatomy such as multiple canals with anastomosis is done, and this helps in thorough cleaning and shaping with the help of CBCT scan analysis and the DOM and magnification. So CBCT analysis is must in such cases, along with other diagnostic aids such as the dentinal map, as we see when we do the access opening. Then the sodium hypochlorite bubble test, that is the champagne bubble test, using the DG16 Explorer and modifying the access cavity preparation. Along with that, we have to use ultrasonics and magnification for such cases for troughing to identify the missed canals or multiple canals. Then the anatomical variations. So clinicians should be very mindful of such anatomical variations in the teeth whenever they are treating such teeth. So beforehand, if a clinician is having certain knowledge that, okay, this case might be a C-shaped canal, or this might be a bifurcation case, or even in maxillary premolars, even in mandibular premolars, there might be cases like this. Even in mandibular central incisors, we can see there are two canals. This is sometimes even visible in two-dimensional X-rays if we take it in multiple angulations. And using the irrigant activation. So irrigant activation is must. So these were my references for the case that I have presented. And I would like to add in a quote that the eyes cannot see what the mind does not know. So the missed canals, they just hide in plain sight until experience, technology, and thorough exploration reveal them. And I would like to acknowledge the head of the department of MGM Dental College, that is Dr. Sumanthini ma'am, my guide, Dr. Anuradha Patil ma'am, she is the professor in MGM Dental College, as well as Dr. Divya Naik ma'am, she is the reader in MGM Dental College. Along with that, I would like to acknowledge Epistate Health Singapore, which gave me a platform to present my case, and in collaboration with SRM Dental College as well as the International College of Dentistry. And for any queries, please feel free to reach out to me. I am Dr. Manasi Surwade. This is my contact number information, and you can contact me on Instagram, email ID, or even LinkedIn profile. So thank you. Thank you everyone for patiently listening.
Thank you, Dr. Mansi. It was a wonderful presentation, very thoroughly explained. I had so many doubts, but after presentation, I'm glad that all my doubts are answered. Thank you so much. But yes, I believe there is one question by Dr. Himanshu. He wants to understand the use of grain activator, or maybe you can elaborate, your activation protocol, though you have clearly mentioned.
Okay, so in activation protocols, as we see, there is either it is sonic or it is ultrasonic. So this Glen activator seems to be a sonic irrigant activation system, and what I have used was the passive ultrasonic irrigation. So both are good. I would not like to say that, okay, this is something this is better or that is better. But passive ultrasonic irrigation is something that I prefer. It does not basically it does not touch the canal walls. So this is the main criteria in passive and in sonic. In sonic, it is touching the walls. So again there would be debris clogging in the apical third. That is something which we don't want. So passive ultrasonic has a higher weightage as compared to the sonic one.
Yeah, very, very nice. Thank you so much. And also, we love the tip which your respected HOD madam, Dr. Sumantri madam, has given you to identify the side, to locate whether it's lingual
Very
or
important.
buccal in DOM. That's a very, very wonderful tip. Thank you so much. So finally, on behalf of our company, we would like to present certificate of appreciation to you. Just a minute, I'm connecting it. All our viewers, the recording of this session will be available on all social media platforms. So feel free to contact us. You can contact Dr. Mansi. She has so gracefully shared her email ID, and you can approach us if you have any doubts. Thank you so much, Dr. Mansi. It was a lovely presentation. Thanks
Thank
a lot.
thank
Thank
you,
you so
everyone.
much.
Okay.
Thank you.